Next, coming to ventilatory support, starting with NIV. Wherein NIV basically, how does it help in acute decompensated heart failure? Cardiovascular system wise, it decreases venous return, decreases RV preload, decreases LV preload, increases pulmonary vascular resistance, increase RV afterload, RV enlargement, and decreases LV compliance, decreases LV afterload, decreases systolic wall stress, decreases systolic BP, and decreases the cardiac output. So, if the patient is in shock, basically NIV cannot be used. A trial can be given, but if there is worsening of the shock and the perfusion, peripheral perfusion, patient must be considered for invasive ventilatory support. Respiratory wise, basically it helps by recruitment of the collapsed alveoli, increased functional residual capacity, maintenance continuous opened alveoli, gas exchange during the whole respiratory cycle. It also increases the intra-alveolar pressure against edema, decreases work of breathing, and increases oxygenation as well. So this is an algorithm based on the European Heart Journal for ventilation, wherein in case of acute heart failure with respiratory failure, if the patient has acute heart failure with COPD, NIV can be considered. In case of pulmonary edema, initial NIV can be initiated. In case of cardiogenic shock, patient can be given a trial of non-invasive ventilation. If not, if NIV is contraindicated, patient can generally be given conventional oxygen therapy. If the patient has intolerance or failure, patient can be considered for invasive mechanical ventilation. For other forms of acute heart failure, conventional heart oxygen therapy can be considered. And in case of isolated RV failure. And if the patient doesn't have, for NIV, if the patient has poor adaptation, non-pharmacological measures can be taken or patient can be sedated. Despite that, if there is failure, and patient can be considered for invasive ventilation. And further, if there is intolerance or failure to NIV, HFNC can be considered. And HFNC can also be considered while weaning off the patient from NIV and taken on conventional oxygen therapy or room air. Next, coming to left ventricular assist device, it is a battery operated mechanical pump, helps the left ventricle to pump the blood. It is a bridge therapy for patient waiting for heart transplant. In some cases, LVAD is able to restore the failing heart and eliminate the need for transplant. Next, coming to right ventricular assist device, basically it can also be considered. It pumps blood from your right ventricle or right atrium into the pulmonary artery and to the lungs. Next, coming to this is the right ventricular assist device. Heart transplant, basically it remains the gold standard for the treatment of advanced heart failure in the absence of contraindication. Post-transplant 1 year survival is 90% with a median survival of 12.5%. The indications for it is advanced heart failure with no other therapeutic options except for LVAD or bridge to treatment. The contraindication, these are the contraindications below, wherein if a patient has an active infection, has a severe peripheral vascular disease or cerebrovascular disease, has pharmacologically irreversible pulmonary hypertension, has malignancy with poor prognosis, irreversible liver dysfunction, systemic diseases with MODS, pre-transplant BMI more than 35, if he has current alcohol or drug abuse, psychologically instability, and insufficient social support to achieve compliant care in the outpatient setting. This is ESC definition of advanced heart failure, wherein all of the following criteria must be present despite optimal medical treatment, that is severe or persistent symptoms of heart failure, NYHA class 3 or 4, severe cardiac dysfunction defined as at least one of these, that is LV EF less than 30%, isolated RV failure, non-operable severe valve abnormality, non-operable severe congenital abnormalities, persistently high BNP or NT-proBNP values, and severe LV systolic dysfunction or structural abnormality. If patient has episodes of pulmonary and systemic congestion requiring high dose IV diuretics, or episode of low output requiring inotropes or vasoactive agents, or malignant arrhythmia causing more than one unplanned visits or hospitalization in the last 12 months. The last criteria is severe impairment of exercise capacity with inability to exercise or low 6-minute walk test distance. Next, coming to INTERMACS profile. Basically, INTERMACS is Interagency Registry for Mechanically Assisted Circulatory Support. It has developed 7 profiles of it has again further divided advanced heart failure into 7 profiles. The first one includes critical cardiogenic shock, life-threatening hypotension despite rapidly escalating inotropic support. INTERMACS 2 is progressive decline, that is sliding fast on inotropes. INTERMACS 3 is stable but inotrope dependent. INTERMACS 4 is resting symptoms on oral therapy at home. 5 is exertion intolerant. 6 is exertion limited. 7 is advanced NYHA class 3. Next, coming to clinical indicators of advanced heart failure. Basically, this should trigger possible referral to an advanced heart failure specialist. So, basically, it includes it is given as an abbreviation I need help, IV inotropes, NYHA class 3B or 4, persistent elevated natriuretic peptides, E is end organ dysfunction, EF less than 35, D stands for defibrillatory shock, HELP stands for H is hospitalization more than 1, E is edema despite escalating diuretics, L is low systolic blood pressure less than 90, P is prognostic medications, progressive intolerance or down titration of goal directed medical treatment. So we have to remember this. Next, coming to management of patient based on the INTERMACS, wherein INTERMACS 1, 2 and 3, 4, wherein short-term mechanical circulatory support can be given. If there is further persistent of severe brain damage or severe irreversible end organ damage, we can withdraw the mechanical circulatory support. If cardiac and neurological and end organ is recovered, then weaning from mechanical circulatory support can be done. If neurologically and end organ recovered but no cardiac recovery, in that case we can go ahead and do a left ventricular assist device can be used as a destination therapy. If there is contraindication for heart in case of INTERMACS 3, 4, if there is contraindication for heart failure, yes, then potentially reversible. If it is, then we can consider left ventricular assist device for the bridge to candidacy. If contraindication is reversed, if yes, then we can go ahead and do heart transplant. If no, then patient can go as a destination therapy with LVAD. In INTERMACS more than 4, wherein high risk, if the patient is high risk, then contraindication to heart transplant must be considered and must be taken accordingly. If there is no high risk, then advanced heart failure therapy, that is heart transplant, LVAD, can be deferred very close follow-up. Next, in case of patient after admission, follow-up must include parameters must be monitored, that is mental status, heart rate, respiratory rate, blood pressure and urine output, and labs that has to be monitored is electrolyte, creatinine, blood glucose, LFT, ABG and lactate levels. Coming to disposition, basically patient with severe respiratory failure, shock, pre-shock must be admitted to ICU. Any one of these criteria present, patient must be admitted to ICU, that is intubated, hypoperfusion, heart rate if it is brady or tachycardia. For patient with acute exacerbation of known heart failure, risk stratification tools can be used. basically they have limited clinical applicability, limited ability to predict outcome, limited available options for measuring any adverse outcome as well. It helps in basically identifying low risk patients who may be appropriate for discharge and treatment in an observation unit, thereby reducing hospitalization rate. So this is a risk stratification scale basically used from ED, that is Ottawa Heart Failure uh, risk scale, which identifies ED patient with heart failure at risk for serious adverse event, including death, MI, need for ICU or intubation. It is best suited for ED patients presenting with heart failure exacerbation who have responded to treatment in ED. It is not intended to be used in determining disposition until ED intervention is initiated. So basically, it includes history. If the patient has stroke or TIA, intubation for respiratory distress if the patient had. Examination wise, if the patient had heart rate on ED arrival more than 110 and saturation less than 90 on arrival, heart rate more than 110 during 3-minute walk test, or too ill to perform walk test. Investigations that include is ECG, which has acute ischemic changes, urea more than 12 millimole per liter, serum carbon dioxide more than 35 millimole per liter, tropi or trop-T level elevated to MI, anti-pro-BNP more than 5000. So based on the level, the scores, it can be risk stratified to see at high risk of serious adverse events. These are my references. Thank you. Hopefully, this heart failure from emergency department is useful for all of you.